All right, I'd like to welcome everybody back today, Alabama Care. And we have the pleasure of having Dr. Laura K Vogtle, who is the director of the Department of Occupational Therapy at UAB, and Dr. Sarah C. Tucker, professor at the Department of Occupational Therapy at UAB. And today we're going to be talking about occupational therapy and kind of doing a soft intro for anyone that's not familiar with it. And at this point, I'd like to hand it back over. Dr. Vogtle, if you would introduce yourself.
I've been at UAB for 25 years. I was a practicing occupational therapist for 25 years, working with children at the University of Virginia. And I still do some work with adults with cerebral palsy, and I also do some work with the Children's Rehab Services Augmentative Communication Clinic. So lots of different hats.
Are you originally from Alabama?
Oh, no, I'm a Yankee. I'm from Massachusetts.
Well, it's good to have you here. I'm originally from Philadelphia, so as a fellow Yankee, I think they say "damn Yankee" when you move here for good.
They do. They do.
And Dr. Tucker, if you would introduce yourself.
Sure. I'm Dr. Tucker, and I also am from Massachusetts. And my practice area is in mostly pediatrics. So after I graduated, I started working in rehab hospitals in Albuquerque, New Mexico, and then here at Children's Hospital. And I've been teaching at UAB mostly in pediatrics, and then I also teach community-based OT, and I've been there for about 7 years. I also started interested in how OTs can work in the community with populations such as the prison population or any at-risk population that's, at risk for incarceration or things like that.
I know the prison system has kind of been a hot topic in the state of Alabama recently. I have a good friend, Mr. James Tucker at ADAP, and he's gone through some, filing against the prison system that they're not doing the right things for people that have a disability or mental health issues. So I know that that's been a very hot topic in the state of Alabama. And between both of your knowledge, anybody that has questions, we do this live on Facebook, so anybody can ask questions in the chat. I'm sure that both of these doctors would be able to kind of address those questions that you have. But I'd like to start, Dr. Vogtle, if you could give us an overview of what occupational therapy is.
Okay, I'll give you mine, and then Sarah, feel free to chime in as we go through. So occupational therapy is a health related service, and basically we work in a variety of settings: acute care, rehabilitation, outpatient, long-term skilled nursing facility, and so forth. And so what we do is we work to improve people's ability to do the things that they care about and the things that they need to do. So things like being able to feed yourself, dress yourself, have a job, be able to communicate with other people, to participate in education, to participate in leisure activities, those kinds of things. And one of the ways that we do that that's rather unique to the profession is that in the process of doing rehabilitation, we will work with the person on the activities that they want to do. So it's not just strengthening and stretching. We do a little bit of that too. But more of our work is geared towards having people do the things that they want to do and help them figure out ways to do that. So it's in many ways a problem-solving approach. It's not me telling someone what to do, but me working with them so they can figure out how to do what they want to do. Is there anything you'd add there?
No, I just like to also say that we kind of our specialty is that we'll analyze the person, the environment, and the activity that they're trying to do. And, and then we help problem solve, figuring out why are they not able to reach those goals? And then how can we either improve like their body functions, so they are stronger to do those things, or is it that we need to do that and adapt the environment, or modify the activity they're trying to do. So we look at that big picture, and it's also not just physical. So we're looking at physical, mental, and spiritual aspects of the person, to figure out, again, how can we help them live a productive and meaningful life, whatever that means to them.
When you're introducing that, a lot of the activities that you both spoke about don't necessarily have to do with finding work. When I hear the word occupational, I think of occupation, and I would go see an occupational therapist to help improve my work experience or get a job. But a lot of occupational therapy doesn't have to do with having a living wage or anything like that and finding work.
Right. And so I get frustrated because my students, like on Facebook, it's OT month this month. So I'll see my former students saying, well, we can't help you get a job, but we can help you do all this other stuff. And my point is, yes, we can help you get a job, because that is an area of occupation. That is something that people do with their lives. So it's not that we can't do that. It's just that's not all we do. So again, we define occupation as anything that's a meaningful activity, anything that's meaningful in your life. So work is one of those things. But yes, I think when people hear occupation, they hear work and they think we're like work rehab, or when you go to like the occupational health people, where you have a job, we are very different from that. But we talk about areas of occupation, like Dr. Vogtle was saying, like your basic self-care areas of occupation, and then play, leisure, rest, and work is one of those areas as well.
I think all of us have heard that very thing, that, well, how can you help my 2-year-old get a job? And it's like, let's restart that and talk a little bit about what we really mean by occupation.
Yeah, I imagine that's kind of the first conversation there. And the way that you're presenting it sounds like a very holistic approach, that maybe some of the things that you're working on and helping individuals overcome those challenges can be adapted in different environments. So if they're wanting to learn that skill for the home, it may transfer over to a work kind of environment there. Now, when you're meeting with individuals, do you have them come in, or do most occupational therapists have them come into an office setting, or will there sometimes be like you're going into the field and visiting that individual at their home?
It's very specific to the type of job that you have. So if you're working, for example, at Children's of Alabama, then you're going to be seeing them at the hospital or in the outpatient clinic. But if you're doing home health, as many of therapists do, then you'll actually go to visit the person in the home.
So becoming an occupational
therapist, early intervention, which is birth to 3, and then we'll see them in their natural environment. So if the child is typically at the home all day, then we'll see them at the home. But if they're usually in the daycare, then the OT can go to the daycare, and see how they're playing and doing motor skills in that natural setting, and train the people that are with them all day. So it really is very setting specific.
Very much so.
So if somebody was thinking about going in to become an occupational therapist, they can kind of decide what career they would want. If they'd want to be more in the hospital at UAB, or if they'd want to focus more on the field work, they have that ability to choose that direction there. It's not a one size fits all.
Right. And it's very, sorry, go ahead. You want me to go? I think it's what's cool about it is when you are trained as an OT, you're trained as an entry level generalist. So you have the opportunity to start in one setting, and then for whatever reason you might decide, like, I thought I wanted to do pediatrics, but now I don't know, there's a job opening at the VA and I feel like I would like to work with veterans and more mental health. And so you can make those changes throughout your career. A lot of new therapists go into hospital rehab settings so they can learn a wide variety of skills. And then maybe they have their own families and they want a more, a better schedule that lines up with their family. So they might transition to school-based OT, where you're in the school setting, you have the same vacations and days off as, the children in school. So people do a lot of transitioning through their career, depending on what they decide they want to do.
And it helps if you're in a mobile family, so that if you're married and your husband moves around a lot, then you can go to different places and then you can fit in pretty much into any particular opening that happens to be there. As well, there are specialty certifications so that you can get a specialty certification, for example, in hand therapy or in mental health or in working on assistive technology or working with adults with low vision. So there are many, many different options out there.
What does the job market look like for someone that may be graduating in becoming an occupational therapist? Is there high demand right now, or what are you guys seeing there?
It's been a pretty steady demand over time. I won't deny that COVID has had an impact. It really has. So as we come out of COVID, I would expect to see things pick up. Because the students who graduated during the COVID were having a little bit of a hard time finding things. But the demand has always been very steady, and we've always been in the top 10 or 20 job openings that are considered the most marketable.
And I think in general now with the baby boomers getting older, the jobs are out there. And also, like, I used to work in the NICU. So we save these children that are, very, very sick, very, very young, where, decades ago they didn't survive. So I think in general, the job market is there and it will continue to grow. I think sometimes what happens is students, when they graduate, want to stay where they're at. So like the Birmingham market is difficult because there's so many OT schools in this area, even though that's such a big hospital, community, there's only so many jobs in those, bigger cities. Like Massachusetts, where we're both from, it's the same thing. There's a lot of OT schools. So, some of those bigger cities, it's harder to get a job. But if you're going to if you're okay going to a rural setting, or you're okay to move, around to different states, there's a job for you. I think it's just, pocketed in certain areas sometimes, or like when the students first graduate, they're all looking for a job at the same time. So it's harder to find a job in those few months, and then they have more success as the year goes on.
It kind of gets saturated for a few months, 3 to 6 months there right after graduation. And I think you hit that spot on. I've been in Birmingham for 4 years now, and I kind of think Birmingham is a medical area. There's a lot of really cool medical things going on here, a lot of jobs, a lot of education. But it makes sense that you might have to move out as a fresh grad and kind of spread your wings in a different part of the country there. What exactly does it take to graduate? What education is needed to become an occupational therapist?
Well, it's changing a little bit. So back when I was in school in the dark old days, it was a bachelor's degree. And then in 2006, they made it a mandatory master's degree. And so right now you can get a master's degree. You can't get a bachelor's degree anymore in practice. Although if you still just have a bachelor's degree, they'll grandfather you in. And then the latest step is to move in, is it 2025, Sarah? Is the move to a clinical doctorate. And so at that point, they're requiring all programs to be at the clinical doctorate level. So it really has gone through a lot of changes over time.
And as far as, you can have an undergrad in any degree. And then the OT schools there's certain prerequisites that you have to take to get in the program. So we'll have people with undergrad degrees in engineering and history and, all kinds of different, maybe they didn't know they wanted to be an OT till they were junior year of their undergrad. So you just have to make sure you take those prerequisites that the school requires for you to apply, and then you can get in. It's a little bit competitive. Like our school, we take 60 students a year. And we always have hundreds and hundreds of applications, each year. So it is competitive. So it's things like GPA and, there's other things that we look at as well. So yeah, I think it's good in that way that you don't have to know right away. But I think we make a push, like trying to find people in high school and make sure they know about OT. Because again, a lot of people don't know what we are or what we do. And so they kind of find this career path later sometimes. And then they have to take all those prereqs, which can get expensive and all of that. So
for sure. Yeah.
Yeah, that's kind of no fun when you have to go back and take some other classes there to get in. But now, how do you guys feel about that 2025 rule or coming in, that additional education? Are you guys in favor of that, or
it's hard every time they transition. You think, is this really necessary? But healthcare is changing so dramatically at this point. There's so much new coming out in the way of technology. And I think the responsibilities have changed some. So, there's some of it I kind of go, not so sure. But then there's part of me that says, yeah, I think we need to really keep up with everything that's going on in our world right now.
Our program is becoming entry-level doctoral this summer. So we are phasing out our entry-level master's program and will be entry-level doctoral. I have to say, like, there's been back and forth about it for years and years, and they were going to adopt it earlier, and then they didn't. But our program decided to go ahead and, do it anyway. So we'll be the first OT program in the state that's entry-level doctorate. I used to teach in an OT assistant program, which is an associate degree, and you have your associate's degree, and you can work, in all those settings we just talked about. And right now, Wallace State is the only OTA program in our state. So that's the bridge between now an OT assistant with an associate's and then an entry-level doctoral student. It's hard to go from one to the other. And to me, having a mandated OT doctoral degree just seems like there's too wide of a gap. So that was kind of my struggle was, what about these professionals that came out with an associate's degree and now want to go back to school to do, to be an OT, and it makes it harder because they'll need a bachelor's degree to even apply to be, to get into these entry-level OT programs. So I feel like there needs to be more programs and things. Like there's a few bridging programs in the country, but not very many. So I do think going to entry-level doctoral makes that gap even harder. And also the diversity in our profession is pretty poor. Like we're dominated by white women in the profession. Right. And so again, I think, requiring this extra schooling and all of that, as much as we say we want to improve diversity and that, I think that kind of prevents certain populations that don't have the financial means or don't have all that time, years and years to get a degree. I think that makes it even more difficult. So I definitely do see both sides of the argument. And it's an argument that continues to be discussed. So it's a challenge.
It's a hot topic nationally, I promise you.
And just kind of a little bit of history of occupational therapy. Do you feel like it's kind of a young profession? Maybe in the last 100 years, something like that. It's really not that it hasn't been done before, but that it's been recognized in this way. And it's still kind of going through some evolution there to be perfected. But I don't know any of the history of OT. If you could give us a little bit of background.
Oh my gosh, let me dig here and Sarah jump in. It was World War I, I believe, that they started. And it was at that time, it was very much a craft profession. So they did a lot of weaving and handcraft and those kinds of things, leather tooling and what have you. And that's really where the history of occupation being things that are meaningful to you came from. And then what has happened since that time is that the profession has just kind of gradually grown. I can't even recall exactly when they became known as a profession where you had to have a license and all those kinds of things. I can tell you when I graduated, there was not state licensure. So at that time, you had a national board that you passed. And then in the last, probably the last 30, 40 years, they've really pushed the licensure now so that I think every state at this point has licensure. So you have to go through a process to get licensed in each state, as well as taking the national boards. Sarah, what else can you add? You teach that one course on occupation and history.
Yeah, and I'll say my grandmother just turned 95, and she was an occupational therapist. So that's how I got into the profession. I was 12, and I was asking her about OT, and so I was looking at OT journals in middle school. So when she started, it was like white nursing coats and a white hat, and they mental health was a big part of it. So we really did start with like what Dr. Vogtle said, but also it was a mental health thing where people started to realize these people in institutions, when they had nothing to do, their mental health declined, and when they had meaningful activity and structure in their day, they actually did better. So that's kind of where it started as well. And my grandmother said, it was like children were sick, so they needed play to kind of, divert their attention from being sick or not feeling good. And now it's evolved way more into science and evidence-based more than it was. And I do think, like, our national organization just celebrated our 100-year anniversary a couple of years ago, and my grandmother and I actually presented together at our national conference, which was really neat. And we talked about the differences and similarities over, when she was an OT and my history as an OT. And a lot of it is the same, the idea of meaningful occupation and being client-centered, but definitely the idea of, like, again, the evidence-based and that sort of thing, I think, because really, and that's why we're talking about entry-level doctoral degrees, is because, there's way more of a push now that the science has kind of caught up. But yeah, even then, no one knew what it was. And, some of the similar, it was very holistic and that sort of thing, even from the beginning.
It's definitely catching a lot of traction, I think, in the last few years. And my first introduction to it was when I moved to Alabama to help take care of a family member of mine. And she is 57 years old and functions at about a 3-year-old level, the doctors say. And she was in the institution in Tuscaloosa, which was part low. And
Right.
we're seeing a big push, and they shut down Partlow, and we're seeing a big push now from the institutions to private providers, and then also now the push is to your own home or your own apartment and people coming into those locations. And that's where I first learned of OT, is speaking with people in the community. And I think it's really blowing up. I think the profession is really blowing up with that evidence base that you talked about. And it's something that we're really going to need. You kind of hit it on the head with the baby boomers. There's going to be a large population of people that are going to need these services throughout the next 30, 40 years. So I hear a lot of people talking about it and then going into it. Like, I'm thinking about going into this, or I'm studying this in college to do this. And I also want to talk a little bit about, you mentioned that if someone was struggling in an institution, just focusing on going out to get a little bit of exercise or doing something that makes you happy, and really kind of where that started from. And I notice on days where I'm having a rough day, if I go for a walk, take my dog for a walk, if I go play hockey, it makes my day a lot better. And then when I'm having good days, if I get in a workout on top of that, it takes it to another level as well. So kind of having that balance, that you have to do things that you enjoy, but you have to be active as well, to the point where if you can be active, be active. I like that history there. What would you advise somebody that is in high school or in college, or maybe going back to college? What would you advise them if they're looking to become an OT?
To shadow, to go spend some time with an OT, and not just one setting, but multiple settings, as we've talked about, is with children, in school systems, there's nursing homes, there's hospitals. There are settings you can't get into for obvious confidentiality reasons, and certainly psychiatric mental health settings that would be much harder, but there are many, many settings. And so one of the things that our program has really pushed for a long time is making sure that the people who come in are sure this is what they want to do. And really the best way to do that is to be there, is to actually experience it. And a lot of our students have family members or friends or themselves who have been through a process of rehabilitation, where they've been through occupational therapy and or physical therapy, and they've seen family members go through it. And some people who are struggling between physical therapy, for example, and occupational therapy, one of the things we always say is go watch, because that's the only way you're going to really figure this out.
Mm-hmm.
And also, I think even if students in high school know they do want to do something health related, PT, OT, speech therapy, again, taking either their bachelor's degree in a similar, we'll have a lot of students that are exercise science or kinesiology or psychology, because then they are taking some of those prereqs as part of your degree, and getting your grades up, because we are looking at GPA and that sort of thing, because it is competitive. And Dr. Vogtle and I will look at applications, and you can see when people don't know what they want to do as an undergrad, they're getting C's and D's. And then when they discover something they're passionate about, all of a sudden their GPA skyrockets because they're excited about what they're learning. So I think, it's one of those things not to be afraid to change. Like if you went in freshman year saying you thought you wanted a business degree and now all of a sudden you're like, oh no, I want healthcare. Make those decisions early and start taking the classes that will lead you towards, a healthcare, graduate program or whatever. In high school, some children in like I knew at 12, so I did everything I could to keep myself to start on the right path. But a lot of high schoolers don't know what they want to do. So, even going to a community college and just taking some of those really general classes while you do try to decide, instead of going to some big prestigious school and have no idea what you're doing while you're there, I think is important too. But I think a lot of it is just high school students don't know that we exist. And, but like Dr. Vogtle said, the more you can just see it and see different settings, because we find that too, our applicants, a lot of times they had a family member, so that's their only idea of what OT is and don't realize it's so broad. The more they can experience as early as possible, the better.
Kind of get a feel for the profession at a young age, just to make sure it fits well with what you want there.
That's right.
Well,
That's right.
We have the two experts with us right now, so I'd like to ask, since you guys are reviewing applications and allowing people into UAB and some people not getting in, is there anything other than the GPA that really sticks out in an application process for you?
Absolutely.
So for the entry level, it is that it's the experience. So, we have an essay component, and that really is what often separates people to get an interview. So the ones, again, that have shadowed in a variety of places and can really talk about, or have a little bit of research experience. Maybe they've, in undergrad, did some sort of research project or had a mentor that helped them, anything that kind of makes them stand out, because that's most students these days in high school have a lot of volunteer service and, in their sorority or their fraternity. And so even though that should stand out, it's actually pretty average, which sounds bad, but it's true. So anything you can say where, again, you've had a variety of shadowing experiences, even if you said, I reached out and talked to a lot of different OTs, and anything that just makes you seem like you've taken that extra step to really understand the profession, doing something a little bit more unique in the community with, again, vulnerable populations, something that kind of gets your hands a little dirty in the community versus, I don't know. I think things like that just make people stand out a little bit more. And that's really what's going to separate people beyond their grades and things like that.
Mm-hmm. And particularly if they have a special focus. So that if it's, if they do a whole lot of different things, that's fine. That's really great. But if they have a real focus on one thing, for example, if they're interested in technology and they've done a lot of things with computers and apps, that's very applicable because a lot of what we do is with computers and apps right now. So, both ways for sure.
Mm-hmm. You've both mentioned shadowing and the importance to get an idea of what it feels like early. Could you give me an example of what a day would look like shadowing, maybe in one type of environment? So if someone was like, okay, I want to shadow somebody, but I'm not sure what that's going to look like, I'm a little nervous. If you could give us an example of what a day of shadowing would look like.
I can jump in with Children's Rehab Services, one of the clinics, because we have people shadow there all the time. So that's a team setting. There's a speech language pathologist who runs the clinic, and then we have a physical therapist, an occupational therapist, we have a rehab engineer, and a social worker. And we have a set schedule of children, and we usually take about an hour and a half per child to decide on if they're eligible, if there's somebody who could use an augmentative device, and if they are somebody who could do that, then which device. And there are many, many different devices out there. So the students come and they sit in. They get introduced to the family. We tell them they're because they're interested. And then we go through the whole process of interviewing the family and at the same time playing with the child basically is what we're doing if they're young children, and they're not all young children. And talk with the child, get a sense of what they're able to do with their hands, with their eyes. How do they respond to the environment, those kinds of things. And then we start playing with some of the different devices and see how they engage with that. Now, some of the children that come in we already have a good sense of what they want, or maybe there's somebody who've outgrown their current system and we're going to move them down the road. So the person who's shadowing gets to sit there and see all of that activity going on. And it can seem a little chaotic sometimes, especially if we have a child who has a behavior problem, who is screaming or throwing things, and we have a few of those. But it's an opportunity to see how people handle that kind of stuff.
I think too, most settings are used to people calling and asking this shadow. So I know it's a little anxiety provoking to call a random facility and ask to talk to the OT department and ask if they can shadow. But our profession, we're used to that. So, most will be glad. We love to talk about our profession because people don't know what it is too. So most of us are, eager to do that. And again, I think it's very setting specific. Like I worked in acute care and rehab, so I loved having people with me, but they'd have to be able to move fast and not, I didn't have a ton of time to talk to them maybe till the end of the day or whatever. And then like outpatient, you might have 6 patients you think are going to come, 2 don't show up. So you have hours where you can talk and, really have that exchange. Or like a school system, you might be in a classroom and watch the classroom and the teacher, and then maybe be with the OT part of the day and speech therapist part of the day. So it can look very different depending on the setting. But most people want you there, and some will limit how many hours you can do. So you just have to ask all those questions, but it really is just picking up the phone or someone that can help you facilitate that. But yeah, it is anywhere where you're somewhere new. It's scary. Like they should always ask what to wear and, all that kind of stuff. The more you know before you walk in, the better. But yeah, I think, it should be considered fun, and you're not going to do it. Like you're not going to be able to do anything with the patient. So, you're not going to hurt anyone. You're just there to learn. So.
It's kind of like a fly on the wall, but attached to your hip. And I would always, like if someone would follow me, I would be like, all right, I want it to be a hectic day to see if you can take this kind of environment.
Yeah.
I know you'd be able to do the
rehab setting. Yeah. In a rehab setting, you might be sitting in a gym, so you get to see PT, OT, speech all at the same time. And that's a lot of times what we hear is, oh, I went to shadow a PT and then I saw the OT working next to them and was like, oh, they look like they're having way more fun. What are they doing? And so, sometimes you go to shadow one profession and you get to see something else that makes you interested.
Now, we were kind of
like
talking
Sarah
about...
said,
Dr. Vogtle, go ahead.
I'm sorry.
I apologize.
That's all right. What I was going to say was, as Sarah said, if you're in an outpatient setting or even sometimes in acute care, somebody may cancel, but a lot of the times you're running. I mean, it is a straight 8-10 hour day. And so you're right. Somebody needs to know if they can put up with that or not.
Yeah. Trial by fire.
That's right.
Now, we talked a little bit about the shadowing experience, and if someone's interested in getting into the profession, what that would kind of look like for them. I'd like to talk about another point there is for the individual and the family. What would it look like for them when someone says, your son or your daughter or you, should look into getting occupational therapy? What is kind of their process in contacting to get it? And then maybe that first meeting to soften that up if they're a little nervous.
Well, it depends on the setting. So if it's a baby who has trouble and they need maybe to be referred to early intervention, then the doctor can make that referral, or the parent can pick up the phone and call and do that. So if they're in the school system, oftentimes they'll get picked up, sometimes because they have a history in early intervention in preschool. So they may have a known disability, and those kids would almost automatically get at least evaluated by occupational therapy and then picked up. And in those 2 settings, you don't need a physician referral. On an outpatient basis or even in the hospital, you're going to need to have an order from the physician written. So the parent would be able to go to the physician and say, I would like my child to be evaluated by occupational therapy. And that would be the process. They might have to argue sometimes, depending on what setting they're in.
And usually we'll have them come in, like if it's with a child and, the parent's there. For example, I've done a lot of behavioral feeding where the child refuses to eat or isn't eating enough or having behaviors around meals. And so again, before you even walk in the door, the parent should have an idea, like, we need you to bring the food that they typically eat, the plate and the spoon and the cup that they usually use. And then there's a lot of going back and forth. So I would be asking the family a bunch of questions while I'm also observing and doing something with the child. A lot of times the child's nervous and they're screaming and crying and won't let go of their parent's leg, and the parent's all embarrassed and frustrated. And we're used to that. That's what, we get child development. So I think anything that can ease the parent's mind that, we know it's not going to always go smoothly the first time. And, so we find ways around that. And I've had initial evaluations where I didn't get to see anything the child usually does because they've cried under the table for an hour. And I just go by the parent report and I try to build some rapport with the child so the next time they come in, we can move forward. But most of the time, we might ask the family to leave the room for a few minutes, because a lot of times once the family's out of the room, they actually will bond with us a little bit. So we might do that. Like certain outpatient clinics have observation windows and sometimes they don't. You just have to sit in the hallway. So I think we just kind of adapt the situation based on what's happening. But we want the family there as much as possible. It's a collaborative thing. We're not asking questions to make, like, I'm not saying like, oh, why did you never feed them this, right? We're always asking in a way to just see the whole picture. And so sometimes we're going to ask sensitive questions and whatever, but hopefully the OT is doing it in a way that makes the parent feel comfortable and that sort of thing. Sometimes we might do like a standardized evaluation where there's forms that either the family has to fill out, like like a checklist, or we might be doing a specific assessment on the child where like we have to do certain items and say a specific thing, because it's standardized. But most of the time we should be letting the family know like what to expect from the session and what the next steps are. So, usually by the end of the session, we'll talk about what we think. Do we think they need some OT? Do we think we need to see them 1 or 2 times to, try to tease it all out? And then we'll come up with like scheduling and, look at the insurance or whatever, however they're going to, pay and figure out what the next steps are.
That seems like it
and
could
if
be.
You're
Go ahead.
I'm sorry. I was just going to say, if you're an adult and in a place like United Ability at Link Point, they have occupational therapists on staff, and they can see the clients just very freely within that setting. I think when Partlow was open, they had occupational therapists on staff, although very few of them compared to what the population was like at that time. So in the adult facilities, if it's an inpatient facility, then usually there's an occupational therapist on staff and it's a matter of getting a request. But if you're somebody at home who has a need, then again, it's an issue of going to your physician and asking.
There's one follow-up I'd like to ask. Dr. Vogtle, you mentioned that sometimes you may have to go back and forth with the doctor before they'll write that referral. What did you mean by that?
Well, I think Sarah and I both having a background in pediatrics. Pediatricians are wonderful people and they take great care of their patients, but they tend to not want parents to worry and just get them going through the natural growth and experience and so forth. But parents are really good about picking up on things that their child is not doing. And so they may say something to the pediatrician who may pat them on the back and say, well, we're going to wait a while, he'll just grow out of it. And so in those cases, you have to have a parent who's really willing to say, I am really concerned and I need you to help me get a prescription, kind of thing. And I think both of us have seen families who have really had to fight the bitter fight to get services for their child. Now, that seems to be more true, I think, with the pediatric population. With the adult population, it's not nearly as difficult as that.
That's one thing that we talk about on here a lot is advocacy, family advocacy, self-advocacy, group advocacy, how to speak up for yourself, those types of things. And when you're going in with this as a parent and you're noticing things that you want to advocate for your child to get occupational therapy, I imagine it can be a little stressful, like you're noticing these challenges that your son or daughter has, and you're thinking in the back of your mind, maybe if we just get OT, this challenge will go away. And you're really hoping for some of those things. And when you go to that first meeting with an occupational therapy, it can be like, oh, this has to go great. Like, son or daughter, please don't act up, and kind of putting stress on the child to act perfect. If you guys see that, it's just like you have to take that shield off.
Oh, yeah. I mean, I think that's what Sarah was describing for sure. Absolutely. Everybody's anxious. Everybody's uptight, from a family client perspective, and getting through that first session is really difficult.
Yeah. And that's where I think all those questions come in, because the child might not display the things that, the family are concerned about because they're not in their natural environment and they're stressed or they're on their best behavior because, they're showing off for a stranger or whatever. So that's why I think just questioning and like building rapport with the parents is so important, because we do, and we're all about routine and that sort of thing. So we're going to ask the family, tell me your typical day. Tell me what seems to be the issue. Is it time of day? What do they act like in the morning versus the afternoon? And just from that, we're going to be able to say most of the time, like, yeah, it sounds like there's some sensory things going on, or something we need to work on. Like maybe it is their fine motor or their visual motor skills, and now they're frustrated because, they're going to school and they can't keep up or whatever. So we can get a lot of that information just through the interview and observing the child. And so I'm a parent. I get how stressful it is to make that decision to go. But I think the worst we're going to say is like, let's wait a little bit, right? But most of the time, if a family is that concerned that they're advocating for their child, they are usually the expert, and there usually is something going on, even if it's something just short term that we need to deal with. But the earlier you can tackle it, the better. There's evidence that is true. And so, and children develop so quickly that, if you wait a couple months, a lot of times you've missed a big window where, you can really start working on those developmental skills at, an earlier time. That's really important. So I think anytime a parent has that intuition that there's something that, needs to be looked at, it's not going to hurt, right? And if anything, it's going to really help the child. And I think sometimes the family needs that validation too, because I think a lot of times friends are like, oh, it's okay, they're going to grow out of it, or, oh, I don't see that, you must just, whatever. And so I think sometimes to go to an expert that can say like, yeah, I see what you're saying. They do seem like they have some sensory things or some behavioral things we need to address. I think a lot of times it's comforting to the family because they've already seen it. They just haven't had a name for it, or they haven't had someone validate those concerns. So, that should be how it goes. Of course, there's always the rare time you get there and it doesn't go as planned, or, it's not the best experience. But for the most part, it should be a really, a very collaborative experience with the therapist and the parent.
Trust your gut. If you're a parent or an individual, trust your gut and get that recommendation and go see Dr. Vogtle and Dr. Tucker. Well, you may not see them directly depending on what's going on. But another aspect of that the parents might be thinking about is, well, how much is this going to cost? This sounds like we're visiting a lot of people and settings. What is the cost to the individual and the family there? How does that work with insurance, non-insurance?
So the cost is going to vary significantly depending on if you're in an outpatient hospital setting versus a private practice setting versus a school system setting where you may not have to pay anything at all. So the answer is it varies. It also varies according to the kind of insurance that you have. So that if you have Medicaid, for example, services are usually a lot more easily accessible. They're easy to get, and the Medicaid will cover those costs. They usually have a limit to how long you can be seen, and you have to do a lot of careful documentation. If you have private health insurance, Blue Cross Blue Shield, any of the others, it really depends on the policy that you have. And some of them cover a lot, some of them cover a little, and some cover nothing at all. So it's a really hard call. You have to really sit down and say, okay, what insurance do you have? And let's look into it and see.
I'm going to kind of
No
put you
easy
on the
answers.
spot. I'll put you on the spot a little bit. You don't have to answer, but if I didn't have any insurance and I was getting OT for a month, but 1 time a week, 2 times a week, what would I want to generally budget to make sure that I could pay that bill?
I'd say $300 to $400.
Okay. I
And
appreciate
again,
you.
it would depend on where. So if it's a private outpatient clinic, if it's hand therapy, for example, that's a specialty. People usually get a lot of education and specialty certification for that, so that might be more expensive. Also, if it's a group, I mean, if you're in a group therapy setting, not many insurances cover groups, but there are some, then it's going to be a little bit cheaper. And if there is a modality involved, and that's not usual in OT, but you see it some, in terms of some of the E-stem and those kinds of things, that may or may not cost a little bit more. So there's lots of variables there, but I would say somewhere between $300 and $400 for a month, once a week for an hour. That's a pretty reasonable cost. Not for the person who's paying it, mind you, but.
And I think too, like a lot of places will, like, say I knew that someone needed a OT eval and didn't have insurance. And the family might say, like, we can't pay to come once a week. And that's where, it might not be best case scenario, but probably what the OT would do in that case is give them some strategies to work on at home. And like maybe they could come less often, or, wait a little bit using those strategies and then see what happens. Or, sometimes what happens is people don't realize that their plan doesn't cover OT because they've never needed it. And so I know I had families where they had to wait till they could re-enroll for the next year and then, pay a little bit more to get a different plan, where it would cover OT. So again, I think most places are willing to, as much as they can, to work with the family, to at least get them started or give them, a little bit to go on. And I think the other thing is just knowing you're probably going to have to wait. I mean, insurance or not, you're going to have to wait a little bit, to get on someone's schedule to get an evaluation. And then, if you only can do 8 o'clock, 4 o'clock in the afternoon on Mondays, it's going to be hard to get someone to be able to fit you in your schedule. So I think that has got to be frustrating from a parent perspective. And even if you have a good insurance plan and you're just doing co-pays, I know that adds up when, you have an injury and you have to go see a PT 3 times a week and you're forking out $30 every time you go to a visit. So again, advocating for yourself, like maybe you only can afford to come to OT, even if it's just the copay, like I only have in my budget to come twice a month, right? And so that's better than nothing. And the OT should figure out how to give you as much as they can give you within your budget.
Pediatric settings are a little bit more flexible than adult settings, I will say that. And it's not that the therapist won't try and work with you in an adult setting, but oftentimes, especially if it's an outpatient for a hospital, for example, then there's not much they can control there, except for the kinds of things that Sarah has said, trying to work with you to see what would best fit your financial picture.
I appreciate you giving us a hard, not a hard number there, but giving us a ballpark, because I wouldn't know if it would be $2,000 or if it would be $100. So kind of giving us that range there, what that might look like. And then Dr. Tucker, talking about those strategies, we see that in the ID community, intellectual disability community, when we talk a lot about somebody being on the waiting list to receive that waiver, those services. And we have a lot of talk around the strategies that you can do at home or on yourself or with your family while you're waiting to receive those services. So when you talk about coming for the first meeting with an OT and getting some of those strategies, even if you don't do it throughout the month, but having that first visit can really make a big difference for you every day, even at home. Now, we only have a few more minutes here, and I do want to ask each of you a question that is more specific to your area of interest. Dr. Tucker, I will start. Some of your interest has been in the incarceration and the prison system in Alabama. Um, what is the biggest factor for incarceration in Alabama?
Whew, we only have a few minutes, so I'll keep it short. But I do have to say, in Alabama, OTs are not involved in the prison setting. In other areas of the country, and especially in other countries, OT really is embedded more in the prison system. So that's my push, is to get us in there, both preventing incarceration, helping them while they're in prison, and then also when they transition out of prison into the community. I already forgot your question. The biggest thing I think is knowing that, again, like they have to have a meaningful routine and have to have the skills, that they need. So in Alabama, in general, in the United States, our population, how much we imprison people is ridiculous. Our numbers are like not even close to the rest of the world as far as how many people we incarcerate. We incarcerate poor people, we incarcerate people with mental health issues. And some of that is because of that deinstitutionalization, where there used to be institutions for people with mental health where, they could reside there. Those are, you're supposed to be able to get those services in the community, but there's not good services for substance abuse. There's not good services for all of that. It's very scattered. So like our homeless population as well, they are at risk for incarceration because they have mental health issues and they go out on the streets and again, they're overwhelmed or they're doing something with substances and they get arrested. And once you start, as soon as you get arrested and you end up in the criminal justice system, the likelihood that you're going to continue on that cycle is really high because you have to pay fines. You have to show up, to your court date. And if you don't have transportation, you don't have money, you can't pay for your driver's license to be renewed. And so the more you get cited for something, the more times you show up in court, eventually the laws, you end up in prison. So, and then once you're in prison, things are just worse for you. You're not getting good treatment. People are getting re-traumatized. So a lot of them come in with a trauma background and then, they're not being treated properly, or there's more drugs in prison than out of prison, which is crazy, but it's true. So people that, you think you go to prison and you're going to get off the substances and come back in the community, that's usually not what happens. And so once they're in prison, or have a criminal record, you try to get out, you can't find a job, you can't find good housing, you're even more poor and even more stigmatized. And so that cycle just continues. They're not getting the mental health services. That's a big thing in Alabama. They don't have enough psychologists and psychiatrists in the prison system. So my push is let OT be a support. We can't give meds and things like that, but we can help with those meaningful things and, giving them the skills. So when they do get out of prison, they have some resources and they have some strategies. So, there's nonprofits out there to support these at-risk populations, but again, trying for them to find them and get there and all that stuff. It just is like layer upon layer of things that are mind-boggling to try to sort through. And again, I think OT is a good facilitator of all those things because we can look at the person, the environment, and really come up with some ways to give them, how do you make a short-term goal? How can you meet small little goals to build success? How can we get peers in your life that are going to help you, that sort of thing. So that's my very long answer. I'm sorry.
We'll have one quick follow-up to that. What does that look like, or where is legislation that you're trying to push to get OT involved in that process, or where about in that process are we as a state?
Well, it's not in OT. That's not in the, I don't think there's a legal push for it. I think it's more networking. And I keep telling my students, it's just going to take certain people saying, hey, let me get in there and do this, for free. Like, let me volunteer to run a group, or like a lot of my community-based class, the students are working with a nonprofit for ex-offenders. So I feel like the more we can show what we can do, like there's a program in Montgomery that another OT gets their students involved that helps moms that have children, while the mother's incarcerated. So I think the more we can get in and do things like that, and show that in other states it really is working to have OT in the prison, like trauma-informed care is all of a sudden a bigger push. So I'm hoping, that's my thing, is advocating for people to start pushing. And I think once there's an OT in there and shows that it's effective, hopefully, that'll just get more and more common.
Grassroots. So getting your foot in the door there. And Dr. Vogtle, I know that you have a commitment at 2:00. So I want to ask really quick. Some of your focus has been on cerebral palsy in aging adults. My family member has cerebral palsy, and I'd just like to ask, what are some findings that kind of caught you off guard during your study, the little insights that you'd like to share?
And it's more, I have done some research on adults with cerebral palsy, looking at ways to prevent problems with pain and fatigue. But also, I have served on national committees and international committees working on some of the challenges that we see in adults with CP. And one of the biggies is loss of function early on. So if you have somebody who's, for example, able to walk, usually by the time they're in their late 20s, early 30s, the amount of walking they're able to do starts to drop, and oftentimes it may completely go away early on. And then they may have difficulties being able to continue to take care of themselves. I'm working with a gentleman right now who was college graduate, drove, held down a job, and now he's totally dependent 7 years later. So there's a lot, and we don't really know exactly why that happens. We have some suspicion. Some of it's the amount of surgery that they've had, how physically active they are, what kind of setting that they're in, and intellectually where they are coming from, and so forth. But it's a very difficult road to hoe, and we've known about the loss of function for a very long time, and we still don't really understand it. So it's a big concern. And as we didn't used to think that children with CP lived into adulthood, but now most of the population of people with CP is adults. And so that they have a number of concerns, and they have tried to advocate for themselves, and I think are doing a better job than they used to be able to do, although the attention still focuses on the children, which is unfortunate.
Mm-hmm. Well, I'm going to go ahead and end the broadcast here. I'd love to have another half hour, so maybe we'll have to do another one in the future.
Sure thing.
But I'd just like to say thank you both for spending this afternoon with us and teaching us about what occupational therapy is and kind of behind the scenes there for individuals, families, and maybe students that are up and coming. So, but at this time, I'll go ahead and end the broadcast. Dr. Vogtle and Dr. Tucker, it has been an absolute pleasure getting to meet you and know you. And once again, thank you for being here with us.
Thank you so much for having us. Yes, indeed. Bye-bye.